thank you all for joining us for the closing plenary here, and thank you for joining us throughout the day. I think this has been, I've heard a number of really terrific conversations, a lot of dialogue and engagement, and I really appreciate you all doing that. I also really want to remind you, and again, thank our sponsors. They have been a tremendous support for us and made this possible. I hope you got a lot of value out of today, and if you have an opportunity to thank them for their support, please do. We wanted to close out the day by sort of stepping back. As we started off today with Nate Checketts talking about some big picture issues, some themes that were there and some issues that were really present for the state. Now we have an opportunity to come at this issue again. So we went deep, and we're going to come back up. And we're going to take sort of a population health focus. Of course, a lot of the themes and a lot of issues we talked about are about population health. So we wanted to really start that off and use that as our framing for going forward. The idea here is not to end the conversation today, but to keep it going and to give it some framing. So I'm joined by two folks. I have Dr. Leisha Nolan, and no relation. She spells it slightly differently. So Dr. Leisha Nolan, who is the state epidemiologist at the Utah Department of Health, and by Carrie Butler, director of the Utah Public Health Association. So I'm going to throw it open, and I'm going to ask you, what do you see as the biggest population health challenge, and how do you think about what Utah faces coming forward?
Sounds good. I think this conference really highlighted a lot of different areas that I could talk about as public health challenges. And I think it's actually a little challenging to pick which one to talk about. But I think one that probably can tie many of us together in this room in our work and in public health and how we approach what we're trying to do is an increasing distrust in what public health and science and the information we're trying to give our population. So public health, we aren't doctors to an individual, we're essentially doctors to the population. And we're trying to get an approach so that we all are healthy and that we recognize different parts of the population are gonna have different health issues and that we really need to invest differently in different areas. So we need to do that, we need to have data, we need to have people engaged. We need to have people willing to work with us. And we've definitely seen since the pandemic, but even truly before the pandemic, that there's been this decreasing trust in public health and really authority and scientific authority throughout. And a really obvious one is our vaccine rates. We are definitely seeing a decrease in vaccine rates. We were even prior to the pandemic. The pandemic definitely bumped that. And we now are having low rates in vaccines that we see that little kids should be getting, that we have all taken for granted for years. And I'm sure everybody has seen the news about the measles outbreak in Florida, and that kind of disinformation and distrust, and it's just seeding more and more distrust when we have these kind of events occur. But from the Department of Health and Human Services side, the public health side, it's concerning because we need information to work. We need to know where we're targeting our resources. We need information so that we can give it back to all of your organizations so you know where to put your resources. It's not worth it to just put out interventions if we don't know that we're doing it right. And so really in our department, we are looking to look at data so we can make decisions of where to invest. And we see this distrust of public health and of health system, of science overall coming to us really even at the legislative level. This session we had a bill passed that puts Utah as the most restrictive law on public health authority anywhere in the United States. We now have a very limited list, actually 7 diseases that we can have people go into isolation and quarantine. And we do have a phrase in there that allows us to put quarantine on individuals if they have a new, re-emerging, or drug-resistant infection, but only with the approval of the public health elected official. So that means we suddenly don't have as much flexibility as we might need. I mean, happily, we rarely use that rule and that law, but to take that away is really concerning, and it just is another step in this distrust and this concern about what public health and what population health really is. So I'll stop there and go. Yeah.
Did you turn it on with the green light?
I did now. Yes, thank you so much. That sums it up quite nicely. There's a large amount of distrust and in public health and especially in this world where we're seeing systems start delving into population health, the lack of information and the reticence to provide or allow folks to have access to that information is troubling. We did see that quite a bit in the legislature this last session. But one of the other things that is impacted by kind of a pushback and a blowback to the COVID is that we are seeing a workforce shortage across the nation and especially in our state of public health workers, which is concerning. And I know we're also seeing a very similar a similar action for clinical providers, right? So we're passing all of these laws that loosen regulations for who can practice and allowing folks to operate at the top of their licensure, which I think is fantastic. That doesn't necessarily impact public health workers, though, and I think it's really critical that we are engaging folks and getting people who have interest in this into proper education and providing them proper resources so that they can then fill the spaces that are vacant and do really good work to help keep folks safe.
So given those challenges, as you look forward, how do we remedy some of those? How do we come at those challenges of both the understanding of public health from a data perspective, but also from a sort of an educational perspective, and then I want to come back to the workforce issues. Let's start with the engagement issues.
Yeah, one thing I think we all need to get better at is talking to the community. We're really good at talking to each other. I mean, my entire training, I was trained to talk to scientists. I was trained as an MD. I got all these really fancy words. I don't say headache. I say, actually, now I don't remember it, but we have. What do you say? I don't know. But we have very specific words that are technical words instead of everyday words. And the same with my PhD training. We got all this really technical way, and you have to put all these graphs in and show every single detail of how the analysis was done and all these caveats and all these different things. And truth is, if you talk to the population, most of our population like that, they aren't going to understand what you're saying. And they're just going to leave the room either frustrated or not. They're just not going to take away what you want them to take. And I think we need to get better at talking like a normal human being. We need to talk like we're talking to our next door neighbor when they ask us how work was and what we did today. My mom always asks me what I do. She does not have any training in this. I have gotten really good at telling her the stories of what I do every day, because she doesn't understand when I'm talking about getting data and responding to different areas and showing health equity. That doesn't make super sense to her. But when I tell her that we had 16 cases of babies born with congenital syphilis last year, and we went and looked at why each of those babies was born with syphilis, and we were able to identify it's people who aren't able to get care until the very end, and they come into the emergency room and deliver their baby, and that baby now is exposed. That's the kind of story like she understands, and she can be like, oh, so what are you going to do about those babies? We need to have those kind of stories, and we need to get good at picking out stories and picking out easy things for people to understand. And I think that's just not just public health, population health. It's healthcare, it's science. We all need to get better at talking to our population.
Anything on that, Carrie, that you want to add to that particular issue?
Yes. As a matter of fact, I think, COVID was rough, and we made some mistakes in public health, and I think it matters that, it matters when we're training up new early career professionals and students in public health that we get back to our public health roots, which is specifically what you're talking about, is meeting people where they're at, right? Not expecting people to know things or understand things or trust certain things, right? I think one of the things I think about a whole lot is that the COVID pandemic happened right around the same time that the opioid settlements were happening, right? So there were pharmaceutical companies who were adjudicated in national federal court to have lied to us as a population, and we expected communities that were devastated in ways that I maybe will never understand by the opioid crisis to then take vaccinations, and we didn't say, hey, we get that this might be scary for you. We said, you take this or you're a bad guy, right? You take this or you're not welcome here. And that was not maybe the best way to handle that. And I think we have a lot of work to do to restore trust. And I think that starts with meeting communities where they're at, and not only translating the way we talk about things into understandable bits of information, but also being curious, coming at our communities, to our communities with a sense of curiosity and not judgment. And I think that certainly will go a long way in helping us understand what they need and meeting those needs better.
So I'm going to talk about the public health. I'm going to use the term public health workforce, but I want to talk about who that is. There were several mentions earlier today about things like community health workers and community-based organizations. When you think about the public health infrastructure and workforce, talk to us about who that is, and I'll start with you, Carrie, on this one, and then come back to you, Alicia. Who is that? And then let's talk about what we're doing to make sure that we have the adequate workforce.
Right, that's actually a really great question. I don't know that we practice this, so let's see how I do. So you mentioned community health workers. They're a relatively new organized workforce in public health, and a group of folks that we are going to come to depend on, I think, stronger than ever to address some of the issues that maybe I can't address or that Dr. Nolan can't address, because they understand them, because they're coming from the communities that we're trying to serve. I think that that's going to be a really powerful group, and I think one of the biggest problems with our community health workers is that at post-pandemic, we don't have a sustainable way to fund these groups. Now, in a lot of states, they're using funding from systems, because the health systems are recognizing what a value community health workers are to population health, and thereby reducing their overall cost health spend. We're not quite there yet in the state, but as far as other groups go, we've been doing a whole lot of work of cross-training clinical workers with the community health work. I think that is a huge step in the right direction when it comes to population health and gaining trust in communities that maybe we don't have, healthcare doesn't necessarily have a lot of trust in. And then of course there are public health, we call them public health adjacent workers. So there's epidemiologists and there's health educators, and those are always the only two that I can ever remember, but there's policy advocates, and there's people who are on the ground, boots on the ground, in communities, preventing, doing tobacco cessation programs or maternal mental health programs, et cetera. And those are all traditional public health, but we also, I think, are starting to think of public health as anything that touches anything that's SDOH. So education and safe routes to school and bus drivers and anybody who is engaged in community efforts to provide safety to the communities. Those are also public health workers, and I don't know that they always think of themselves as public health, but I think it's important that we consider them in the public health system.
Dr. Nolan, what about you? Who do you consider to be your soldiers in the field here?
Yeah, well, certainly the people who work with me. And in the Department of Health and Human Services, we have a huge number of people who are so dedicated to this. And I do think those people in the field, like the community health workers, but I also do think clinicians are so a vital part of this, and we forget them so often. It's one part of my mission, actually, is to try to engage clinicians in, because the truth is, all our data comes from clinicians. So if we don't have clinicians out there well documenting their cases, we can't tell what's happening. If they don't call us when they see that fourth really weird infection, we're not going to know something. So one of my missions is to try to get clinicians more engaged. I've actually started a public health grand rounds. So grand rounds is a classic teaching thing in hospitals, and now trying to get it into the public health realm. So making sure they also feel engaged, because we need the data from them, but we also want them to work on the data, right? Like, we want them to take that data and use it to inform how they're doing their practices.
You know, Carrie, you connected SDOH to public health. As a last question from me, and then we can go to others, or if there's other comments you have. looking forward to how we get momentum. How do we get back on the right track as we think about this in terms of connecting public health to SDOH? What's the process where we're going to hook onto to get population health and public health as a core fundamental process here?
That's
Another good question, right, that we didn't practice, because
Yeah,
we
we
didn't
didn't
practice
practice
any
that.
of this, so.
So, okay. Here is the great debate that some of my advocate friends and you, we had this conversation last night. What is the thing that is motivating people to make change in places of power? So it was legislative session. You guys all heard me like bum out about the legislative session. I'm really sorry, but that is a place where people hold an inordinate amount of power over how we do things in public health and your job in particular, and how we gather data. And somebody said something last night that has been ruminated, like kicking around in my brain a whole lot, and that was how do we get to a point where the people in power are acknowledging that A, everybody needs to have health care, and B, when we do things right, that health care becomes cheaper. So the thing that we argue about in advocacy a whole lot is what is going to sway somebody more, stories or money? And I happen to think it's money. A lot of people think it's stories, but I think it's money. I think anytime that we invest in public health infrastructure, we are reducing the overall cost of healthcare. I think that there are plenty of stories and plenty of studies that indicate when we invest public health dollars, we see that return in the health systems. And I think that that's an important message to push out. And I think the more that we can talk about that, the more likely we are to see movement in places of power that really make a difference, right? So when we invest, for example, in good education, we have better health outcomes. We know kids who go to early or who receive early education 60 years down the road or 50 years down the road have better health outcomes. We know this, and yet we are very reluctant to put money in here. And I think that's one of the things that is going to have to happen and change is providing education to the people who are making these decisions so that we are investing up front, even if we're not seeing the cost savings for 20 years.
I think it's really unfortunate that social determinants of health have become politicized, and certainly our state has shown that to a very large extent. But I do agree with you. Unfortunately, I think this state really, a lot of people resonate with money. And I think we need to start thinking about how we talk about social determinants of health as almost a best investment for our money, right? If we want to really use our money to the maximum, we should invest in those communities where it's going to have the biggest impact. I don't want to give my money to the very wealthy of Park City to get an intervention there. I want to do it someplace where it's going to have a big impact. So I think even in this climate of a lot of hesitancy around these, I think we can phrase it in a way that people are going to still accept and be able to make those differences and make sure we still consider those other factors that are affecting people's health.
Do we have any questions or ideas or things people want to put forward from the context of what you've been talking about today? Yes, please go ahead.
So I just wanted to ask, so I know that you guys talked a lot about like building trust in the community. And so I come from a place of like diversity, right? And I know that in my community, there's not a whole lot of trust for like healthcare, right? Especially, and I also am a CHW. And so during COVID, I had the hardest times, especially with my family, just like getting the vaccine because they felt as if like there was that big stigma around it. Like you said, like you must get it. And so they kind of like, there was a big pushback. I want to know like where you guys see us going in terms of like the future and how we maybe like as a CHW, where can I come in and kind of assist to mend that gap?
Does somebody want to take that question, and can you repeat it just so that we can make sure that folks heard it in the back?
Yeah. So I don't know your name, but our questioner here asked how to work with communities that have really been marginalized, and I'm totally. marginalized in the past, and that she's a community health worker, and during COVID, she found that a lot of her community members were just not very hesitant about these new interventions because they have past history with it and problems with it. I actually think community health workers are an amazing resource that we invested in during the pandemic that we cannot let go. That is a big future for how we should be doing these all kind of health, all kind of public health. We need people who are part of the community to talk to their own community. I look very specifically like one community. If I go into your community, they're gonna just think of, that white girl from over there. It doesn't help. So we need to really invest in getting people who are community members to be educated so they can be advocates, but educated so they can be advocates that have all the information. Because I know that community health workers get really complex questions. And it's hard to answer those, so make sure we keep on investing in that, both in terms of making sure they continue to be employed, but making sure we continue to invest in education in those kinds of resources. And I think there's no question we need to make sure that we get people in all sorts of levels, government, medical care, all different levels from all different communities, so that when people go to care, they see people like themselves there.
So a lot of challenges emerged today, a lot of ideas, I hope, a lot of linkages, and a lot of conversation. I really appreciate ending at this point of, to some extent, where we started, but also the challenges that are ahead and how we keep moving forward. So please join me in thanking our panelists, and thank you all for joining us today. Really appreciate it.